Hello, we're here to talk about falls in people with cirrhosis, who, why, and how to prevent them. Before I turn things over for introduction to my co-host, Dr. Susan Murphy, I'll introduce myself. I'm Elliot, a hepatologist at the University of Michigan Health System and Veterans Affairs of Ann Arbor, where I care for patients with cirrhosis and complex liver disease. I have a passion for and conduct research to prevent falls in patients with cirrhosis.
Hi, I'm Susan Murphy. I'm an occupational therapist and a researcher at the University of Michigan and at the Veterans Affairs of Ann Arbor. And I am very interested in learning more about how people are falling or not falling with cirrhosis. I have worked for the last 20 years in researching and treating older adults, and can see how older adults have a lot of the same problems as younger adults with cirrhosis, which we'll talk about.
So to lay out a roadmap for today, over the next 15 minutes or so, we will review why patients with cirrhosis are at higher risk for falls, what these falls mean in a broad sense for patients, and then we'll focus on strategies that you can begin now on how to prevent them, whether you're a patient or a provider who cares for patients with cirrhosis.
So falls are a big problem for adults. In older adults, considered 65 years or older, about 1 in 3 older adults fall each year. And it's the leading cause of fatal and non-fatal injuries in older adults. Falls are really problematic in adults because they lead to bad consequences, physical disability, sometimes nursing home admission, and even death. Falls are common in cirrhosis. However, we don't know as much about how falls occur in people with cirrhosis. But we do know that they occur in people that are less than 65 years of age, which means that we should start focusing on it earlier. And we know that cirrhosis makes falls worse. The condition increases the risk of falls, and it also makes recovery more difficult. This slide shows how people age and how their function changes over time. So when you start out as a kid and as you get older, you probably don't think about the hazards around you, but they don't change. The only thing that's changing really is you over time. So you might slip as a young adult and not fall because your ability to withstand that, because of your body's abilities, is not impaired. But as you get older, your muscle mass and strength progressively get worse, and it leads to problems with walking and balance. And in cirrhosis, this is actually an accelerated process. So you may be feeling some of these things earlier on, but the consequences of cirrhosis that Dr. Tapper will talk about is associated with fall risk.
So extending this concept, basically what's going on in the bodies of our patients with cirrhosis accelerates that aging process. So we all know roughly what cirrhosis is: scar tissue replacing the liver, hindering its ability to do the tasks that we ask of the organ. But the reality is that most people with cirrhosis don't know it, and for the most part, compensated cirrhosis, the earliest form of cirrhosis, is a silent condition associated with risks, but generally not associated with decreases in quality of life or increased risks of harm. But when a patient develops portal hypertension, and that is the blood flow of the body starts to be redirected to, for example, develop varices or increase the size of our spleens, that is a sentinel moment where the toxins that the liver would have otherwise handled with ease are now being distributed to the rest of the body. And when this system is stressed even further, a patient will develop what we term a decompensation. And this is experienced or felt as hepatic encephalopathy, the confusional state that can wax and wane and treated by lactulose, etc., or ascites, the development of fluid in the belly, and variceal bleeding, bleeding from the varicose veins in the esophagus. And it is over this spectrum, as one develops each of these hits on the liver, that a patient's quality of life will decrease, and with it, their risk of death will increase. Typically, we begin to see that the liver is a little less able to do what we asked of it metabolically to process toxins and other things. Patients will develop portal hypertension, varices. And when the toxins start to be distributed through the body, those toxins are themselves harmful to the muscle. The muscle is asked to take on the role of the liver and detoxify things such as ammonia. And I'm going to talk a little bit more about the role of ammonia in subsequent slides. And as people develop further decompensations, so their quality of life will decline further, progressing to a state that can be rescued only by transplantation, or failing that, unfortunately, increased risk of death. So in this slide, I'm going to talk about ammonia. We've heard about ammonia. It's a toxin that comes from our gut, mainly by bacteria eating the protein from our own diet. But because of portal hypertension, because our liver doesn't work the way that we want it to when we have cirrhosis, that ammonia is distributed to the rest of the body. And its consequences are many. One is that although the levels of ammonia are not perfectly predictive for hepatic encephalopathy, ammonia is the principal cause of confusion or hepatic encephalopathy, which can present as mild cognitive disturbances, irritability, decreased executive function, or all the way to coma. And many people know that this is, for the most part, reversible through treatments such as lactulose and or rifaximin. But what many people don't know about ammonia is that when the liver is not doing the job we ask of it, other organs in the body pick up the slack. And the key place of ammonia detoxification turns out to be the muscle. So I'm going to walk through how the muscle handles ammonia, and I'm going to show you how this process is key to understanding fall risk in patients with cirrhosis. So you start with ammonia. It's a toxin the liver can't handle. In order to get that ammonia out of the blood, we need to combine it with glutamate. Glutamate is an amino acid. Where does it come from? Our muscle actually has to break down muscle fibers to produce that glutamate. It will make glutamine. Now, this is less toxic than ammonia, but it's not particularly useful. So what ends up happening here is that the expense of clearing ammonia from the blood is muscle breakdown for something that isn't particularly nutritionally valuable. And for that reason, we're constantly telling people that have portal hypertension, high ammonia levels, and hepatic encephalopathy to eat as much protein as possible. And there was an old school thought that we should reduce the amount of protein that patients with cirrhosis eat, because protein metabolism is where the ammonia comes from. But that's a short-sighted thought, because if we restrict protein, we restrict our ability to build back the muscle that is needed to detoxify the ammonia. So this process of high ammonia levels is a double hit for the risk of falls. Number one, ammonia is one of the causes of hepatic encephalopathy. And number two, ammonia is one of the causes of muscle wasting. So if you're confused, if your nerves aren't working the way they should, you might be more likely to fall. And if you stumble and your muscles have been weakened by this process, what we call sarcopenia, you may be less likely to compensate for any given stumble or perturbation. And so ammonia is at the center of fall risk. So just to review, the ill effects of cirrhosis are many and add to risks for patients. We know about the portal hypertension. I've explained to you how it causes muscle breakdown or sarcopenia, and how ammonia metabolism is at the center of that. But you also have to remember that many people with cirrhosis are malnourished. They have ascites, so they don't want to eat, or they don't have access to food, or they've received advice not to eat protein. All of these things contribute to the risk of reduced functional capacity. You're no longer able to work. You're no longer able to care for yourself. Cognitive dysfunction, all of the toxins that lead to that. And hepatic decompensations are also contributing to that and worsening each of these processes. For example, ascites will make all of this worse. In the center of this, what we see in practice is frailty. You're just not able to do what you used to do. How this shows up in the clinic is that you could have a fall and with that an injury, or you're hospitalized for any number of reasons. Being frail or having reduced functional capacity is associated with hospitalization for any reason. And once you're in the hospital, we keep you stuck in bed where you may not be well nourished, where your muscles don't have stimulus to work. And an unfortunate happening is that there's a adverse cycle of hospitalization and further frailty. And if interventions are not initiated to rescue people from that downward spiral, the end result can be disability and death. So if we take a step back from that conclusion, we know that falls are happening in patients with cirrhosis, and they're happening in a particular risk group that is of interest to me. And those are people with minimal hepatic encephalopathy. They haven't been admitted to the hospital with coma from encephalopathy, but they're starting to experience the cognitive deficits of early encephalopathy. There aren't great diagnostic tests for that, but we should be pursuing them. And when we do, for example, through batteries of tests with a neuropsychologist or apps such as the Encephalap or inhibitor test, we can define people who have minimal hepatic encephalopathy. And it turns out that it's those people, including those people who have had a history of overt encephalopathy, hospitalization, coma, etc. Those are the people who are at highest risk for falls. Up to 40% of people with minimal encephalopathy will have falls. And that when you are a fall, you start falling when you have cirrhosis, it is those people who have the worst quality of life. So all of these processes that are leading to falls are driving the way that you perceive the world in very negative ways. And so when you give all people with cirrhosis a questionnaire to ask them about their quality of life, if you happen to have had a fall in the last year, you are much less likely to rate your quality of life as high. Falls are negatively contributing to our quality of life. Now, Dr. Murphy and I have studied falls for patients who have come to the emergency room. So if you take all people who came to the emergency room with falls in the United States and looked at who among them had cirrhosis, and then asked, well, what happens to those people? It's a very sobering story. So it turns out that falls are happening in people with cirrhosis because of their unique physiology. 2, falls are more likely to happen in people with cirrhosis because of all of the problems that we've discussed. And when patients with cirrhosis fall, they are 2 times more likely to experience a bleed in their brain. They are 2 times more likely to tear a hole in one of their lungs, thorax. 2 times more likely to develop a rib fracture. And just under 2 times more likely to fracture their pelvis, their skull, their femur, their arms. So when people with cirrhosis are falling, they're far more likely to be grievously harmed. So for this reason, you can see how falls are not only contributing to adverse health, but also a poor quality of health. It's hard to take care of somebody who's had a fall. They're less able to do activities. They've injured themselves. They're afraid of going out because of falls. And so it's no surprise that when patients with hepatic encephalopathy, who are the most likely to fall, if you ask caregivers how they're doing, 36% of caregivers have lost insurance or are missing healthcare appointments. More than 50% have stopped saving because probably they're less able to work. 46% are in debt. So there are cascading negative effects that are associated with falls, both for our patients and the people that care for them. So the obvious question is, what should we do? Well, the first step is to classify who's at risk for falls. If you have hepatic encephalopathy, you're at risk for falls. But even for people who have not had that condition, there is still many people who are falling. So I just want to go through a couple of steps because these apply broadly to patients with cirrhosis. These are some of the things that your doctors clinicians are doing to assess the benefit of liver transplantation even. So the first thing that we do when we look at somebody is we perform a subjective assessment. I have on this slide here the Karnofsky Performance Scale, which is what we report when we're listing people for liver transplant. It was developed originally to determine who would benefit from one of the original chemotherapies. And basically you can be an A, B, or a C. And as an A, you may have limitations because of your cirrhosis, but you're still able to work. A B is not able to work, but is still able to care for themselves. And a C is now no longer able to care for themselves. So obviously, if you can't care for yourself, you're at high risk for all kinds of adverse events. If you're unable to work, that is also true. But if you look at this group of A, there's still a whole spectrum of risks that we need to define better. So for that, we need to probe one step further. And we have a variety of assessments that can assess fall risk and function. This includes your strength through hand grip, how many times you can stand from a seated position in a chair in 30 seconds, or how fast you can walk 10 meters, or how far you can go in 6 meters. These risks of frailty can help us understand who might be at risk for adverse events in the short term, even if they're still able to work or care for themselves. Karnofsky Performance Scale is associated with outcomes in patients with cirrhosis. You're much more likely to be delisted from a liver transplant wait list if you have a Karnofsky B or C, or unfortunately die before or after the time of transplantation. But there's a lot of work that shows beyond that, irrespective of your performance status, that how strong your hands are, how fast you walk, how many chair stands you can do, are all associated with important outcomes in patients with cirrhosis. So while these scales have not been used yet to stratify patients' risk for falls, this is what we recommend, this is what we intend to do in our research.
So the next couple slides just talk about what are evidence-based interventions to reduce your risk for falls and to prevent falls. And the goal is to really focus on prevention. You don't want the fall to happen. So even if you don't have hepatic encephalopathy, anyone who has cirrhosis, this is very important to think about. What you want to talk about with your healthcare provider is your fall risk and how people normally address fall risk in the older adult population is they do a battery of assessments because there are some established fall risk factors. So we know that some medications increase your risk for falls. poor vision and your ability to see contrast, like stairs, being able to differentiate where the stair is to go down or up, hazards in your home, your balance, dizziness from getting up from a sitting or laying down position, difficulty walking, trouble thinking clearly, poor sensation, and poor footwear are all fall risk factors. And as you've heard earlier, a lot of these things are associated with having cirrhosis. So in addition to addressing specific fall risk factors that you have, the thing that you can do today is exercise. And there's a lot of evidence that shows that almost all exercise is pretty much equally effective in improving your health. So whatever you want to do is going to be good for you. Walking and balance and strength training are all important. For sarcopenia, it's important to do strength training, and walking can help a lot with other conditions that you might have, and it contributes to heart health. Being more physically active, small things that you can do, starting with a 10-minute walk per day and working up to more time is really beneficial. There are effective fall risk reduction programs. The Otago exercise program is sponsored by the CBC as a very effective falls reduction program. The research over the last 20 years or so has shown that it reduces falls up to 30 to 40% in the people that follow that program. And physical therapists help with that program. They come into people's homes and they show people how to do the exercises, and then people need to do them over like a year period is when they have shown the effects. Tai Chi is also a very effective exercise for balance and postural control, and a combination of aerobic and resistance exercises are recommended. So what you can do is talk to your healthcare provider about falls, and this is especially true if you've fallen in the past or if you are fearful or concerned about your risk of falling. Your healthcare provider can go through fall risk factors and get you to the right intervention or adjust things appropriately. They can consider a physical therapy referral for an exercise program or for strength training. You can also assess your home for safety hazards, and there are many checklists online. You can also request an occupational therapy referral, where an occupational therapist will come to your home and will work with you and people that care for you or your family members to look at your home and evaluate the safety of you in that environment. It's important for you to prioritize exercise and fitness. As Dr. Tapper was saying, it will not only help with falls, but it will help with your overall health. In this last slide, we're showing you some links to useful resources where you can find out how to check your fall risk. You can check on hazards in your home. There's a lot of really nice resources online. We have a couple here for you. There's also a very nice exercise program from Go for Life, which is a National Institutes of Health funded program. You can go online and you can download exercises. You can track your own goals, and you can get a lot of resources through that site. So we want to thank you for your time and attention, and hope you got a lot of useful information out of this webinar.